Okay, Christian, we are online now.
Yes, we are online and we are ready to go.
Good.
Yeah.
Okay. So, hello everybody, and welcome to the new edition of our series of webinars for the World Federation of Neurorehabilitation. I'm very grateful to Stephanie Clark, Sonia Cortez-Abez, and Juan Du to help us with this webinar today on a very important issue on treatment of unilateral neglect and what next steps we should go. So, welcome to this meeting. Let me express my gratitude to our glorious team in Romania, Christian and his friends, who help us broadcasting this very efficiently all the time. And Stephanie, please start.
Well, thank you very much, Volker, for your kind introduction, and hello to everybody. We are very pleased to be able to share with you few thoughts on the rehabilitation of unilateral spatial neglect. You may wonder why we should be talking about it. The diagnosis is clear, everything is clear, and yet we may have some problems. And we hope with my colleagues, Yuan Liang Tu and Sonia Krota Herbet, to bring a few thoughts on the topic which could influence our clinical practice. I will start, if I could share my screen. Okay, now uh, well, unilateral spatial neglect is a tricky thing. It's very frequent, and it corresponds to the failure to report, respond, or orient to novel or meaningful stimuli presented on the side opposite a brain lesion. When this failure cannot be attributed to either sensory or motor deficits. This is a very old definition, but it's still valid. As of you know, the neglect for the left part of the space is much more frequent than the opposite. And this is due to the internal organization of our brains. Well, clinically, you can observe this in patients' behavior. You may go to the acute station, talk to a patient with a right hemispheric damage, and you are on his or her left side, and he or she won't respond. Typical sign of left hemispatial neglect, because if you go to the other side, the patient will respond. Then the patient may fail to eat food on the left half of his plate, not shaving the left half of his plate, not being able to read the big titles in the newspapers because he ignores what's on the left, and so on. Later on, often the deficits are much more subtle. There is also motor neglect, which is the failure to perform movements despite preserved muscular force. Now, assessments, there are formal tests which have been published. There are batteries which are very currently used where you have the limits of normal performance. They include cancellation tests, line bisections, other types of visual tests, but also other modalities like listening and tactile modality. There are several very well constructed batteries of ecological assessment in conditions, behavioral assessment. Now, this is one of the easiest tasks, which is used often from the acute to the chronic stage. This is a cancellation task, meaning that the patient has to cancel here with the red pencil items. Here, these are lines. It's an easy test. And this is a performance of a patient with unilateral neglect. Another one, which is often used and often reported in clinical trials, it's the line bisection, where the center of the line is indicated far too much to the right. Now, one very important thing for today is to remind ourselves that hemi-neglect is a modal deficit. There are obviously dissociations between sensory modalities. You can have visual-only neglect or auditory-only neglect and so on. But even within one modality, like the visual spatial neglect, there are surprising dissociation, and they have been documented in terms of double dissociations, meaning that there are patients who have the one deficit but not the other, and vice versa, who have the other deficits but not the first one. This has been shown for near and far space, for perception versus visual imagery, or if you look at an object or a drawing for global aspects of this object or local details. And then there are types of neglect which are viewer-centered or stimulus-centered. This means that there are maybe different systems, neural systems involved. Now, the lesions which are typically present when there is hemi-neglect are, as we mentioned before, right hemispheric. This has been described very early on. They involved very often the parietal cortex, the frontal cortex, but also subcortical regions like parts of the thalamus, basal ganglia, internal capsula, and other smaller structures. There is a series of studies who investigated the anatomical correlates of acute and chronic neglect. These are studies of Otto Karnat's group, which dates some years ago, and you see that in the acute stage, neglect is associated with lesions which involved the parietal frontal, temporal, and partially occipital cortex, but also subcortical structures. In the chronic neglect, there are only smaller lesions or smaller parts of the brain may be involved, but they are both anterior, like the basal ganglia, and posterior. Now, how does unilateral neglect evolve? In the acute stage, many patients have signs of unilateral spatial neglect after right hemispheric lesions. But within a couple of weeks, they often improve, and they improve spontaneously, even without rehabilitation. Basically, the study of Neighbor and colleagues has shown that this phase occurs within the first roughly 3 months. Now, obviously, as a specialist in neurorehabilitation, we are very much interested in specific interventions. And they are in different classes. Some teach the patient to attend to the left by training visual scanning, by visual motor cueing, by kinetic stimulations, by video training, or forced use of the left visual field or left eye. Then there are approaches which aim to restore the interhemispheric balance, like TMS and direct current stimulation. There are there's a whole class of approaches which plays with multisensory representations, vestibular stimulation, vibration stimulation, transcutaneous electrical stimulation, but also prism adaptation. These methods have been investigated. Some of them are in these last years more than the others, and we will hear about them. We will hear about the clinical trials, the latest clinical trials on these topics, and about the neural mechanisms, the neural underpinning of some of these interventions. Now, the next part of the webinar is devoted to two talks. The first talk will be given by Yuanliang Tu, who is a doctoral student in her last year at the INSERM and CNRS in Lyon, at France. And she will address the issue of what randomized controlled trials tells us. After this talk, we will have some time for specific questions, and then the second talk will be by Sonia Cotter-Hedbeth, who is a senior researcher at the CHUV and University of Lausanne in Switzerland, and she will address the issue of brain imaging and clinical practice in unilateral neglect. Well, I am passing over to Yuanliang Tu.
Thanks so much. Okay, now I will share my screen. I need the organizers allowance. Okay, I can share my screen. Okay, good afternoon, everyone. I'm Yuanliang Tu, a PhD student of Lyon University 1, and I work at the trajectory team of CRNL. And now it's my third year for my PhD study, and I will study for 4 years in here. And my supervisor is Professor Eve Hosity. And today I feel very honored to have the opportunity to share my work in here. Maybe you already noticed that the glasses I wearing in my individual photo is very special, right? Actually, this is prism glasses. So next, I would like to briefly introduce what is prism adaptation first. Prism adaptation, it's one of the oldest and classic paradigm used to investigate the sensory motor plasticity. And in the classic paradigm, subjects, they will be asked to do a pointing task, and including 3 different sessions: pre-test, pre-exposure, and post-test. The pre-test is used to measure the normal visual-motor coordination, and in this phase, subjects, they point without visual feedback. It means they look at the target and then close eyes and then point to a target. In this phase, most of subjects, they can point accurately to a target. And during the prism exposure, subjects, they will wear a pair of prism glasses passively. And in this phase, because the prism glasses, it can shift subjects' vision field to right or left. In this case, it's rightward. So in initial phase, subjects, they point to the right of a target. However, in this phase, subjects, because they point with visual feedback, so they can see their pointing arrow. So in the next trials, they will use the arrow feedback to correct their pointing. So after several repeat trials, they will point close to a target again. And in the post-test, the glasses will be removed, and the subjects, they will point to the opposite side of the target because of adaptation. And if we record the arrow means the lateral distance from the pointing to the target. We can get arrow curve like shows in this figure. We can see that in the pre-test, the arrow is close to 0, and during the pre-exposure, the arrow reduced gradually and finally close to 0 again. And in the post-test, they point to the opposite side of the target. And if we compare the post-test to the pre-test, we can get after effects, which used to magnitude the amount of adaptation. The pre-adaptation first applied in spatial neglect in 1988 by Eve and his colleagues, and they found the patients' spatial neglect symptoms improved when comparing to the control group because the intervention could bias the eccentric reference and increase the spatial attention or perception and the affected side of the patients with spatial neglect. And in the past 27 years since it first applied in clinic, there were a lot of RCTs published. However, the results of these RCTs remain inconsistent. So it's important to determine the effect of PA intervention and spatial neglect. So 3 related meta-analyses published in succession. However, there were several new RCTs published recently. So we conducted the meta-analysis in 2025. And during the revision process of our report, there was another related meta-analysis published in 2025 by Unilateral and his colleagues. And they reported a significant short-term effects and also indicated that the larger pressure shift means equal to or greater than 10 degrees plays crucial role in the PA efficacy. This provided important guiding for the future clinic research. However, this study, the main focused on the short-term effects and also a single PA intervention parameter, the prism magnitude. So we planned to expand the work based on the previous meta-analysis. We aimed to investigate both short-term and long-term effects, and except single PA intervention parameter, we also want to investigate the effect of overall intervention dose. In our study, we searched in 4 databases based on our inclusion criteria. The participants with spatial neglect and defines the PA group as the PA or PA plus conventional treatment, and the control group as sham PA or sham PA plus conventional treatment or only conventional treatment. And for the outcomes, we included all the behavior or psychological tests, And finally, we got 10 available studies. And for these 10 studies, actually each of them reported at least 2 outcomes. However, after calculation, we found that the CBAs and the BIT are the 2 most reported scales, and they can reflect the 2 different aspects of spatial neglect. The CBAs reflects the daily life improvement, and the BIT could measure the task performance under the structured setting. And because the CBAs is more sensitive, so we set it as our main outcome and the BIT as a secondary outcome. And also we categorized the assessment time into short-term and long-term. And for the detailed outcomes and the assessment time have shown in this table. For the included 10 articles, they published from 28 to 2023, and almost of them are right hemisphere stroke. And we also extracted the basic information like age and the mean time post-stroke, and also intervention for each group, and also extracted the PA intervention parameter like wait a minute, like duration and the frequency and the total sessions and total exposure. So let's see what happened in our results. First, for the CBS, for the short-term effect, there were 7 articles included. And if we look at the forest plot, we can see that each horizontal line represents 1 study, and the effect size was reported as weighted mean difference with 95% confidence interval. And the pooled diamond means the pooled effects, and its width means the confidence interval. If it does not cross the 0 line, it means the improvement is significant, different between groups. So we can see in our results, it's significant. And for the long term, there were 4 studies included and showed no significant difference between groups. And next, it's for the results of BIT. We can see that in the short term, 3 studies included in the BITC and showed no significant difference. And in the long term, also 3 studies included in the BITC, and the effect did not reach statistical difference. So at present, we can see that we only observed the significant difference in the short-term effects for CBS. And in order to investigate which factor or parameter could modify the PA intervention efficacy and spatial neglect, we did exploratory linear regression only for CBS, not for BIT because it's limited sample size. And we investigated the participants' characteristics, that is age and days after stroke, and also the PA intervention parameters like prism shift, a number of trials per session, and the number of sessions, and also frequency and so on, and found nothing significant. This is maybe because limited sample size. So in order to further explore the modifier factor, we conducted exploratory subgroup analysis based on previous evidence. One parameter was prism shift based on the dose response relationship in the most recently meta-analysis by Unilateral. We categorized our study. We categorized the studies into 2 subgroups: the larger prism shift and the smaller prism shift. And the second parameter was total exposure, which could reflect the overall intervention dose. I can explain it more later. So let's see what happened for the subgroup analysis for the prism shift first. For the short term, we can see that all of the included 7 articles, they employed larger prism shift. And so the result was identical to our previous analysis. And for the long term, there were 4 studies included, and 1 employed 6 degree, and the other 3 employed larger prism shift. And if we look at the results, we can see that in the larger prism shift subgroup, there was no significant difference. And next, let's see the results for the subgroup analysis for total exposure. We calculated the total exposure as number of trials per session multiplied by the total number of sessions and multiplied by prism shift. And according to the half of the maximum total exposure among the included studies, we categorized them into 2 subgroups, less than half value and equal to or greater than the half value. If we look at the results, we can see that in the short term and in the smaller total exposure subgroup, there were 2 studies included and showed no significant difference. And we only found the significance in the larger total exposure subgroup with 5 studies. And for the long term, for the included 4 studies, we found that 3 included in the smaller total exposure subgroup and showed nothing significant, and only 1 included in the larger total exposure. So based on all of these results, we can see that significant effects of PA on spatial neglect were observed in the short-term CBAs and all the studies with larger prism shift. And the effect mainly derived from the studies with larger total exposure. And why there was no significance in long term, we thought that maybe it's because it's limited total exposure, or it also could because inter or intra heterogeneity, like different severity of spatial neglect or the different lesion sites. So for the future, firstly, we should encourage or consider the effect of larger total exposure. And also we should consider the individual heterogeneity. We can do a stratification based on the different severity of spatial neglect or the different injury nation. Just like in the Mizuno study, they categorized patients into mild and severe spatial neglect. And also, except the pointing task, we could also encourage the diversity task training, like in Shirashi's work. They ask patients to do like a rental scheme at home, so it can help increasing the fun of task and also diversity. And for the outcomes, we think that the assessment should also be performed in a dynamic environment. Okay, these are all the contents I would like to share today. So next, if you have any question, please feel free to ask. So thank you all for your listening.
Thank you very much. That was a very clear presentation of the recent randomized controlled trials with prism adaptation, we have a few questions related to it and one which is in the wider context. First question by Dr. Mohsen Shafizadeh from Sheffield. Prism study, why did you use meta-regression to find the effects of some variable instead of subgroups analysis?
Because the limited sample size, for example, for the short term of CBS, the number of articles reported is only 7, so it's less than 10. So we didn't use regression. We didn't use a meta-regression analysis. We just do an exploratory univariate linear regression to investigate. Yes. This is because of limited sample size.
Thank you.
Thank you.
And now another question, this time from Dr. Natalia Toncheva. How do you define long exposure? In your recommendations, I suppose.
You mean the larger total exposure?
Yes, it's probably long exposure in terms of a treatment, whole treatment, yes.
Yes, because we think that one is that we should use larger pressure shift like equal to or larger than 10 degree. And also we should keep the longer exposure during each session. And also we can increase the intervention frequency like twice a day, and also increase total number of sessions so that our total exposure could be larger, and maybe we can observe the expected long-term benefits. If I answered your question.
Okay, thank you. We have a more general question from Dr. Mohsen Shafizadeh from Sheffield. How much changes in the eye structure after a brain injury, for instance, stroke, can be responsible for visual neglect? Do we have any evidence of visual perception adaptations in eye movements through eye tracking technologies to monitor eye movements after a stroke and following an intervention because of visual neglect? My point is, do we expect any structural adaptation declines in the eyes movements, gaze control, object tracking, etc., or neglect is just a central problem in the brain in terms of sensation and perception areas? Well, I was wondering whether we should keep this a reply after Sonia Kota-Edbet's talk. What do you, because you would answer that, wouldn't you?
Yeah, we can do it later.
So I will not directly answer that, but I think it's a very long answer. Not so much. Keep it at the end, that would be better. Yeah. Volker?
Okay.
Yeah.
Okay, we leave it for the end.
Stephanie, if you allow me, I like this talk very much, but what it shows is the aporia we always have with randomized controlled trials. We have that in almost every domain in neurorehabilitation. And there's a reason for that. I think at the moment, we still, all of us, believe in randomized controlled trials and in the epidemiological framework of randomized controlled trials, meta-analyses, and all of this Cochranian type of analysis. The problem, however, is that all of this may at the end preclude progress in the field. And that is a very severe problem, which is not that easy to handle. We have seen that for decades, that even procedures which today are standard and save hundreds, thousands of lives, originally following this framework were discarded as being non-effective. The ECAS trial for thrombolysis is a good example of that. And after changing the analysis structure in a sense that going away from the simple truncation to a more complicated truncation, suddenly it appears to be useful, right?
Mm.
And it's used every day in every hospital around the world now. We have similar problems
Yeah.
in many other fields. And you have expressed that very elegantly, that, if you have patients who definitely do respond to prism adaptation. But when you go for randomized controlled trials, then of course, due to the heterogeneity of the populations, due to the heterogeneity of the procedure, and eventually due to factors we are not aware of because they are very individual. They may be traced by some sort of biomarkers, but in actual fact, we don't have these biomarkers as yet. So the question is, if this is a provocative statement, and it's meant as a provocative statement, if we just rely on randomized controlled trials, we will miss an awful lot of possible opportunities. And we have to keep that in mind, right? I'm not very fond of just using randomized controlled trials. It's imaginable for me that if you have a patient who responds, you could use it, right?
Yeah.
And we have to bring this down again to a more individual basis. We are talking a lot around the world on precision medicine or individualized or customized or whatever you want to call it medicine. But this, of course, is in marked contrast to the rationale of randomized controlled trials because they are necessarily group statistically based.
Mm.
And group statistics, especially when you go down in supergroup statistics as meta-analyses, then you water out possible effects. And we have to be more careful in not losing this important information we have obtained from individual patients. So if there is something that works in a patient, you should use it. Irrespective of the fact that an RCT doesn't show a statistical effect. That is my position to that.
Well, I can only agree, and I couldn't have said it better. Well, our point is that on the one hand, we have these very nicely done trials, as explained, which have some drawbacks and do not show what we believe should be the case. But there are reasons for that, and the reasons are the neural mechanisms involved. And this is the next talk we will be hearing from Sonia Corta-Herbet about the impact of brain imaging on clinical practice. Sonia.
Yeah. Do you see my screen?
Yes.
Okay, just like that. So actually, thank you, Volker, for the point that you raised, because I think it's a very, very good introduction to my presentation, actually. So I will talk to you about the impact of brain imaging on the clinical practice and the case of prism adaptation in spatial attention deficit. So by spatial attention deficit, I mean unilateral neglect or neglect, and I will not, I will skip a little bit the first few slides because I think Stephanie and Yang Liang already presented what is neglect. So you all know that it's a patient with left deficit after usually right hemispheric stroke. And here I'm showing you rehabilitation approaches used in neglect. So usually we have two different axes. Either we use a modulation of the cognitive process, and here we are talking about top-down modulation, or we are using a bottom-up approach relying on the modulation of sensory motor process. And that is where we have prism adaptation, which is the focus of the topic of my talk and of the previous one. So as you know now that prism is using prism adaptation is using glasses with a deviation of the visual field. So the real position of the object are deviated. And as you can see here, that's the real position. And when you start wearing the prisms, the position is shifted to the right when the deviation of the prism are leftward. So here it's a video. Okay, video don't work. Okay, no problem. But you've seen that when we start wearing these prisms, first there is a shift to the right because of the deviation of the glasses. Then there is repetitive pointing movement that leads to an adaptation. And then the pointing movement are actually deviated to the left because of the deviation. So as you heard, there is a beneficial effect of this kind of method on prism adaptation, on spatial neglect, and I will skip that because you already heard. And one of the limitations raised by the previous presentation is that randomized clinical trials show limited efficacy of prism adaptation. And the discussion we had with Professor Volker Hornberg just after the previous talk was about why do we have these limitation in randomized clinical trial. And one view is that first, there is not a lot of randomized clinical trial of high quality. A lot of them miss a good control group. Different procedures are used during prism adaptation. There is a variability in terms of measures, outcome, time post-stroke, treatment doses, duration, and follow-up timing. And quite often, the samples are often too small. So I think that all of these reasons show that an explanation of why there is a decrease effect of prism adaptation efficacy when we do group analysis. But one of the remaining question is not all patients respond equally well to prism adaptation, and why is that the case? So to determine which patients are responders versus non-responders, we conducted several studies using neuroimaging. And I will first start with studies from other groups, and first with a structural neuroimaging that can be used as a tool to improve the clinical use of prism adaptation. So first, a study conducted by a group in Geneva. They splitted their patients in two groups, one group with more parietal posterior lesion and one group with more frontal anterior lesions. They did one session of prism adaptation and they look at the efficacy of the decrease of neglect sign in a bisection task and in a visual search task. They show that the group with more anterior lesion, frontal group, has an efficacy, a higher efficacy with a higher improvement following the prism adaptation session in the bisection and the visual search task compared to the group with parietal lesion. So here we already have in quick view that the position of the lesion might impact the efficacy of prism adaptation. Similarly, in another study conducted by Chen and colleagues, they splitted their patient in two groups. Again, a group with more frontal anterior lesion and a group with more posterior lesion. And again, here they show this time after 2 weeks of prism adaptation with daily session, they show a higher improvement in the group with frontal lesion here in black. You see the lower score means less neglect. So there is a higher improvement in this frontal lesion group compared to the group with no frontal lesion or more posterior lesion. In another study, again, comparing frontal and non-frontal groups, but this time they included control groups, so a group that didn't do prism adaptation. They look at neglect deficit, and the only group showing a significant improvement is this one. It's the group with frontal lesion doing prism adaptation. So from that, we can already have a cue that there is a higher improvement after prism adaptation in patients with more anterior lesions compared to patients with posterior lesions. Here in Lausanne, we conducted also a study looking at the effect of the lesion location, and we split it this time not according to the lesion location, but according to the response to prism adaptation. So we did a group of non-responders and a group of responders. And we show that we look at the lesion, the position of the lesion, and we show that in the group not responding well to prism adaptation, first, there is a larger lesion, but the lesion includes these regions, large part of the temporoparietal and frontal cortex and the underlying white matter. In the responder group, you can see here the lesions are smaller first, but they are more anterior. So there is a sparing of the region here that I'm showing here, sparing of the posterior white matter regions. So if we want to summarize the impact of the lesion location, we can already see that there is less or even no improvement after prism adaptation in patients with more posterior lesions, and there is better improvement in patients with more anterior lesions. So it seems that PA responders need or have a spared posterior parietal region, and the interhemispheric middle and posterior callosal fibers are spared in the patients that are good responders. So now we are questioning why is there a dissociation between anterior and posterior lesions in the efficacy of prism adaptation. And that's where we looked at functional neuroimaging to be used as a tool to improve, again, the clinical use of prism adaptation and to explain why there is such a dissociation between anterior and posterior lesion on the efficacy of prism adaptation. So we conducted a series of studies using functional MRI and a very simple task that you can see here with targets that were presented on the left, on the right, or in the center of the screen. And the subject has just to press a button when he detected a stars, the visual stimulation. So the patient did such a task in the functional MRI. They went out of the scanner. We did a prism adaptation session, standard. And then they went back in the scanner, doing again the same visual detection task. And we compared brain activation before versus after the prism adaptation. And here I'm showing you first the results on the control subject. In red, you have an increase of activation after prism adaptation. And in green, you see the region that have a decrease of activation after prism adaptation. So I highlighted these two regions with the yellow box because they are part of the region involved in the dorsal in blue here and in the ventral in orange here, dorsal and ventral attention system, or also the DAN and the VAN. You can already see here that the dorsal attention system is involving equally the left and the right hemispheres, while the ventral attention system involves more the right hemispheric. So this is a schematic representation of this asymmetry with higher involvement of the right hemisphere compared to the left hemisphere in attention, especially for the ventral attention system. And you see that these regions that I highlighted here with the yellow boxes are part of the ventral attentional system. So in control subject, after prism adaptation, we have a left hemispheric dominance of the attentional process. And here I did a schematic representation of that with a higher involvement of the left inferior parietal lobule, the left ventral network in the attentional processing. And that is the modulation consecutive to the prism adaptation. So in patients, we conducted a study using, including 15 patients. You have here, you see the overlapping of the lesion of these 15 patients, so only right hemispheric stroke. And again, we look at the increase or decrease of brain activation after prism adaptation. In red, again, there is here the increase of activation. You see the increase is larger in the left hemisphere compared to the right. And that is true for when the targets are on the left, but also when they are on the right. And here again, the schematic representation of the dorsal and the ventral attentional network. In black, it's a representation of the lesion of these patients. And after prism adaptation, we propose that there is an increased activation in the left hemisphere in this patient, which is the spared hemisphere. And this is that induce higher modulation of from the ventral to the dorsal attentional system via the inferior parietal lobule on the left spared hemisphere. So when we go back to the responder versus non-responder question related to prism adaptation, putting all together the results we observed in the lesion studies and in the functional studies, we can conclude that there is an importance of the integrity of the posterior and posterior periventricular white matter regions that are here. You can see here that they are spared. And this region is involved in the modulation by the left hemisphere on the right and left attentional system that are spared in the neglect patient. So it is important to have integrity of this region to have an efficacy of prism adaptation. At least that's what our results showed. So in conclusion, what are the anatomical predictors of successful prism adaptation? First, the lesion studies we did and other group did show that anterior lesions, frontal, lead to higher improvement than the posterior lesions. So it's important to have spared dorsal attentional regions, including the superior parietal lobule, the intraparietal sulcus, the posterior part of the temporal lobe. They tend to be spared in patients showing good response to prism adaptation. Neuroimaging studies provided explanation on the mechanistic, the functional mechanistic view with spared ventricular white matter fibers that convey interhemispheric, that have a link between the right and left posterior region of the dorsal and the ventral attentional system. So here you have a representation. We propose with our model that when we have these fibers that are not damaged, that are not damaged, patient will be good responders. But in patient with damage, posterior damage on the white fiber conveying on the white fiber of the posterior region, here there is a missing link between the right and the left hemisphere, and that's explain why some patients are not responding well to prism adaptation. So I think that taking that into account when we want to use prism adaptation will help to really target patient will be good responder to these methods. Okay, this is my conclusion.
Thank you very much for this very clear talk. Now, basically, what you recommend is that when a patient comes to neurorehabilitation with a severe neglect, you should look at his scans, MRI or CT scans done in the acute stage and know where the lesion was.
Exactly. I think that's very important. At least that's what several studies, several groups showed. And yes, patients with more frontal region will tend to have better answer to prism adaptation.
Yes. Well, I don't see any specific questions to this second part, but we could go perhaps to this question which Dr. Zafizadeh asked about eye movements. Are eye movements concerned in neglect? Are they normal, abnormal? Who would like to respond? Sonia or?
So we are We are conducting a very large study using immersive virtual reality that include also eye tracking recording and eye tracking movements, analysis of neglect patient. So what we showed, but it's really preliminary, is that after prism adaptation and after all 2 weeks of prism adaptation, there is a better movement of gaze toward the left. And so that would explain that before the treatment, patients were really looking more on the right, and then after treatment, they look more balanced on the right and left space. But I think that's not new, because it's quite well known that patients neglect they neglect the visual space, but this neglect is not related to visual perception. Is really a central attentional problem. So it's not because the patient doesn't look to the left that he has neglect, but when we can improve the eye movement to the left, I think it will also impact, it will decrease.
Yeah.
But it's not a direct link between eye movement and neglect. Did I answer the question? Not sure.
Okay, well, thank you. We have now a special questions for imaging. Dr. Sorrentino, do you know of any studies that used tractography to explore these lesions? I suppose lesions linked or not to a satisfactory response to prism adaptation.
So tractography has been used in several studies on neglect, but it was more to determine the white matter lesion involved in neglect. And there is a lot of studies led by Paolo Bartolomeo in Paris. They show that even patients with focal damage of the SLF2 can have a neglect deficit. But from my knowledge, I don't know studies looking specifically at tractography and efficacy of prism adaptation.
Okay.
No.
Thank you. Well,
May I make a short comment?
mhm.
Sonia, this was an excellent talk, making some points really very crystal clear. It's not having the frontal lesion, it's sparing the parietal lesions, probably, which is the point.
Exactly.
But it's a good example that knowing more about individual inherent brain dynamics will help to classify if interactions work or not. The problem, of course, we are faced with is that imaging, and not even functional imaging, is not available everywhere.
Mm-hmm.
So the question always is what elementary answers we can give from the existing information, which can also apply to, let's say, low-middle income countries and countries with a much lower level of technological diagnostic and assessment tools. And probably to know that a patient with a bigger parietal or posterior lesion is probably not a good candidate for prism adaptation may, of course, help. What is your opinion about the generalizability of this information?
Okay.
How far this can be generalized on a more elementary basis?
Yeah. So I think that just a CT and MRI would provide some.
Yeah, sure.
But I agree.
Even
But
a structural CT.
if we don't have CTs and MRIs, which happen in a lot of places in the world, for me, the fact that prism adaptation is very easy, not expensive tool, I would say just use it. You will never just try. You will never harm the patient. And there is still, visual stimulation, motor stimulation that are used during the treatment by itself, because there is this pointing repetitive movement. Visual tracking must be done by the patient. So even if the real mechanisms behind prism adaptation doesn't work because the patient has posterior lesions and you don't know it because you don't have access to imaging. I would still use prism adaptation because it's quick, it's not expensive, and it still has visual and motor stimulation for the patient. So even if it's not the best tool for your patient, I would say just use it. So here in Switzerland, we try to use it in different settings during physical therapy or hand therapy. So I think there is a lot of occasion to use these glasses, even if it's not strict pointing movements, but these glasses can be used anytime during any kind of treatment. So I think it's still worth using that, even if you're not sure that it works on your patient, but it will never harm or lose time of your patient.
Yeah, it's just trying it out, and if it
Yeah.
works, it works. That's basically
It's
it.
not invasive, so
Yeah.
use it.
Yeah.
Well, this is a very simple heuristic approach, which
Not scientific slash
no,
scientific.
no, the question is science doesn't start with statistics.
No,
Yeah.
exactly.
Science
Well,
starts with observations.
Mhm.
And I think we have to keep that in mind again, that it's not on big data alone. Big data can be extremely helpful, but it's on good observation, which may help to find
Mhm.
individualized way to treat a patient, I'd say.
Yeah.
well, I would like to thank both speakers. Thank you very much for your excellent presentations. We have obviously addressed only one of the treatment options, but all you public, my colleagues, you may understand why, because we need to understand the mechanisms. We have very precise data. Therefore, it was so limited to one particular approach. But now we have a surprise for you, because we have one of the founders of Prism Adaptation with us at the Lyon site, Yves Rossetti. Eva, can we say hello to you?
Sure.
This
Yes,
is the
sure.
author of the paper who started all this about prism adaptation. Hello, Eva.
Hello, thank you, Stephanie.
Mhm.
It was
We are,
really listening to the
yes,
talks, and I'm really happy to be here and listen to that and know that, see that so many people were interested in the webinar.
well, yes.
And
Well,
I have 1 minute, I can tell you a really funny anecdote. When we came up with the idea of using prisms with my friend Gilles Rode,
mhm.
was an intern in rehabilitation, and I was a young scientist coming back from Japan, having learned about prism adaptation, and I knew nothing about neglect. And he knew about neglect. He was doing his PhD on neglect. I knew, and he knew nothing about prism adaptation. One day, his supervisor was missing, and I needed to help. And then I discovered about neglect, and I said, "Oh my God, you're using the same test as we used to assess, quantify prism adaptation to quantify neglect." So for me, it's obvious we should try prisms for neglect. So it was nothing thoughtful, just a lucky chance that we had to find this out. And then we immediately went to discuss to his supervisor, who said, "No, forget about it. It will never work." So it took us another year to say, well, it's so easy, we should try. I mean, even if they don't believe it works, then we should try. And then we tried, and we had these brilliant results. So we submitted it to a neurology journal, and it was rejected. And the
And
first
then?
voice in the lab said, "Why don't you try nature?" I said, "Why not?" After that? So it's really difficult to see that we were lucky at several stages and to get this paper that made prism adaptation so successful in the following years.
Well, thank you. I mean, it's a very good argument to go to have a coffee or tea with your colleagues
Exactly.
in the next building who are perhaps basic neuroscientists or, on the other hand, clinicians.
Luck
Well,
may be better than thinking.
yeah, yeah. Thank you very much.
Right.
Thank you, everybody, for attending this session, and all the best for
Yeah.
all of
Also from
you.
my side, my gratitude to Stephanie and the speakers for this afternoon. Was a very good, I think, a very good meeting. We had an almost record attendance, as far as I can see from my monitors, about 200 people or so, which is more than we usually have on these WFNR webinars. And let me also thank the audience. Let me thank our technicians, Christian and his team, who always do a very good job in doing that. And hoping to see you in the next WFNR webinar, which will probably be not in December, but in January, as far as I can see at the moment. Thank you very much. Take care. And if we don't meet before, have a nice holiday season. Thank you very much.
You too. Okay, bye-bye.
Bye-bye.
Bye.
Congratulations.